and their success with the Telehealth eICU initiative there at their organization as they connected with a variety of rural communities, again brought by Summit Healthcare. So I just wanted to do a few quick housekeeping items. We will be getting you a copy of the presentation as well as I'm taping it, so I can also get you a link so that you can review the presentation either for yourself or pass along to your colleagues. Also want to let you know we will do a question and answer at the close of the presentation and a very short demonstration of the technology platform, only about 5 to 10 minutes or so, which will be led by Matt Johnson, Product Manager at Summit Healthcare. So with that, I do want to introduce Ross Stoll, who's Supervisor of Enterprise Systems and Integration at Avera Health. Ross did this presentation out at Muse, the Muse International Show, and it was very well received, and it really is a really amazing and great accomplishment there for Avera. So without further ado, Ross, I'm going to go ahead and turn it over to you, and we look forward to the presentation. Thanks so much.
All right, thanks, Tara. Yeah, like Tara said, my name is Ross Stoll, and I am the Supervisor of Integration here at Avera Health. We'll run you through a little bit what got us started in looking at this eICU project and kind of show you what it's doing and let you know how using Summit has been a great benefit to us in using this project. So let's move on. All right, a little bit about Avera McKinnon and Avera Health itself. Avera McKinnon is a member of Avera Health, and within that and these numbers are growing all the time, so they're only accurate as to the day that this slide was made. We got 231 care locations in 81 different communities across 5 states. Those 5 states are North Dakota, South Dakota, Minnesota, Iowa, and Nebraska, and we have over 12,000 physicians and employees within Avera Health. We have plans of investing another $800 million in capital expenditures in the next 10 years. Avera McKinnon itself is the largest of the 5 regional hospitals within Avera Health, and Avera McKinnon does have 506 beds. We have 550 physicians and 60 distinct specialties. And like I said, we are part of a 5-hospital region that goes across South Dakota and Minnesota with the regional hospitals. We have award-winning care, which includes the 100 most wired hospitals ever since they started giving out that award, as well as being the most wired, and we are also the most wireless. So however you can do those both at the same time, I'm not sure. But now we'll get into why we looked at getting into eICU care. Back in 1999, there was a report sent out that was called To Err is Human, and that report shows that there were 98,000 Americans that die every year from preventable medical care. Well, they created a group called the Leapfrog Group in 2000, and they came back with a recommendation that said they had a potential of saving 57,000 lives if you go along with the recommendations that they had. Their initial guidelines said that you should staff, the ICU wards should have an intensivist on staff there at the ICU. And they said if you did have an intensivist on staff at your ICU, you could probably, if everybody did, we could save around close to 54,000 lives. Sounds all great, except we would need around 30,000 intensivists to do that in the United States. And currently nationwide, there's only around 8,000 intensivists that are available. And if we look at ourselves, just in the region that we're in, we've only got a little over 300 intensivists that are even available to us. So that brought up a glaring shortfall that we have in intensivists, and we had to figure out how we're going to get around that. There were also other things in our region that made this even harder. The fact that we're so rural. We've got 66 counties in South Dakota, and of those 66 counties, only 2 of them are urban. The rest are rural, which have a lot smaller, like our critical access hospitals. And then 34 of them are frontier, which there's not even any cities in a lot of these counties. Also with that, we've got a huge aging population. The number of older boomers in South Dakota grew by 3.1%, which makes us the 7th fastest growing rate in the nation. And then the cost. The average cost per day of an ICU floor is $2,500, where it's only $625 for a hospital inpatient floor. So we're seeing all of these things adding up together, going, and we can really make a difference if we can move forward with this. That's when we decided to go ahead with this eICU care. Now, eICU is a registered trademark with the company that we use, which is called VisiQ. VisiQ is owned by Philips now. Our chief medical officer at the time that we went live with eICU was a huge proponent for us, and he pushed really hard, and he was wonderful. His favorite thing to say when he went out to show this to people was that eICU is like air traffic control for ICU patients, and he was exactly right. So in September of 2004, we opened up in 4 of the 5 regional hospitals that are in Avera: Sioux Falls, Aberdeen, Mitchell, and Yankton. All 4 of these are in South Dakota, but from Sioux Falls, it's about, I think, about 70 miles to Yankton. It's about 60 to Mitchell, and it's about 220 to Aberdeen. So you can see how far spread we are throughout our region. We were the 11th site to go live with eICU in the nation, and VisiQ will tell you that we are the most widespread because we're so rural and we go across such great miles. Like I said, we went live with the 4 hospitals in 2004. Since then, we've grown to now have 33 facilities going across 6 different states. Now, nationally, there are 10% of the ICU beds are monitored by an eICU, which there's about 50 eICUs, and that's growing all the time in the United States. Now, in South Dakota alone, 60% of all the ICU beds are monitored by Avera. We get USDA grants every year, and we've also gotten private foundation grants. One of the largest ones is from the Helmsley grant. Here's a little look at what we have for tertiary facilities, and then look at the large number of critical access hospitals. And I think this is where it really pays for itself, and we'll explain that a little more as we go on too. And there's a map of South Dakota, and the orange dots of all 33 of the facilities that we're currently monitoring, where you'll see the farthest one away is Gillette, Wyoming, and Douglas, Wyoming. So currently in our eICU, we have just one intensivist. He's there for 20 hours a day. He goes there from noon until 8 in the morning. The reason they're not there from 8 in the morning till noon is that's when most of the ICUs have doctors on staff that are going in and actually doing rounds on the patients. So we didn't figure we needed to duplicate that. We have 2 nurses that are there 24 hours a day and 1 secretary. And currently they're able to monitor between 60 and 70 patients at a time. eICU was our first eCare. Now Avera has expanded on. We've also got eConsult, eMemergency, eStroke, and pharmacy, urgent care, and nursery also. So once we saw how well this whole eICU was working, it really got us to push forward on the rest of the suite. I don't know, I imagine all of you have heard of Apache, and this is a system that's built into the software. Apache has been around for quite a while, and they estimate the survival of a patient as they come into the hospital. And so we've used that as a benchmark to figure out, okay, here's what Apache says should happen. What's happened to us since we got the eICU? And the numbers have really proven themselves. The patient outcomes, our mortality rates have declined, length of stay has declined, ICU days were saved, and patient transfers avoided at the costs associated. And that's a huge one when we think about our critical access hospitals that are hundreds of miles away. And when we get into some of these smaller communities, it's a long ways to get to even the next city, let alone next large city like Sioux Falls. So one of the huge things is a patient comes into these critical access hospitals. They're now able to stay there close to their family, and the family doesn't have to pack up and travel to Sioux Falls or Aberdeen or one of the larger hospitals. So they save on having to get hotel rooms to be close to their loved ones. So that's been a huge bonus for them also. Here you can see a little bit, the Apache predicted ICU mortality is the blue line. And for the ICU and the hospital both, the mortality when it was sitting at 1, you can see that our numbers ever since we went live with eICU are well below what Apache predicted. As well as the length of stay is the same way. And here is what we're showing. So you see pre-ICU down there, we were in around that 325 in the negative for ICU days. And ever since then, the ICU days saved because of eICU have just gone off the chart, and it gets more and more all the time. This particular one shows these hospitals that we're showing right there are critical access ones. And we're saying that had we not had the eICU, these patients probably would have been transferred out of those facilities and sent to a larger facility, like one of the 5 regional hospitals. So the fact that they were able to keep them there in their own hospital has been a huge savings for these critical access sites. As we talk to the director of our eICU, she'll tell you that there's also a lot of challenges that came along with it. As we bring on another site, if they happen to be in another state that we're not currently monitoring, we have to get all of our doctors licensed and credentialed for that state also. And then the integration of the technology we put in as a challenge, but we're seeing that that's becoming easier and easier with every one that we go forward with. The relationship building and trust. As you can imagine, the doctors at first in these rural sites are a little hesitant to want to give up their ability to treat that patient to somebody else. They feel like, this is my patient. I don't see how anybody sitting in a room 200 miles away can take care of them. But we find that the further and further that we get into it, the doctors are more and more receptive. The business model that goes along with this, the sites purchase the equipment that's needed, the camera and the servers, speakers, and all of that stuff, and they also pay for the T1 line for the data between them. There's a monthly fee that Avera charges them per bed monitored, and none of these charges go back onto the patient. And the expenses that they're putting into this, they feel, are being recouped by the positive outcomes. So before I get into this, I'll give you just a little example of exactly how it might work. The doctor, 2 nurses, and the secretary sit in an office right in downtown Sioux Falls. Actually, right now they're on the campus of Avera McKinnon. They'll be moving off here shortly to where they won't even be at a hospital campus. Every one of these sites, these rural sites, have they have a camera in every room that they're monitoring. There's a button on the wall, and all this information is flowing into our, what we call the core. That's where the doctors and nurses are. If there happens to be a problem that they'd like to talk to a doctor in the core, they can hit this red button. It'll pop up on their screen saying somebody in Spencer, Iowa would like to talk to you in this room. They can camera in and actually have a face-to-face talk with them. The camera can zoom in on the patient and check them. At the same time, we're getting lifetime vitals showing up on the screen. And then the software itself has a lot of algorithms in it that uses what we interface, like their labs and meds and their vital information, and it will trigger what are called smart alerts. Now, if some labs come through that are showing really low, it will compare what they're giving them for meds and it'll give them suggested treatment plans. What's those suggested treatment plans that a human being sitting there is not going to necessarily be able to pick up on right away? That's where the savings in ICU days comes, because some people were being mistreated. So we'll move on with the technology infrastructure. With the Philips eICU, which was VisiQ, they have an integrated technology with clinical decision support and standardized evidence-based care being leveraged by the eICU team, which is our team sitting in that office building right here in Sioux Falls. Here at Avera, we're integrating 33 Meditech facilities with Philips eICU, leveraging the Summit Express Connect interface engine. We went live with our interface engine about 3 or 4 months before we went live with the eICU, knowing that we were going to need something very robust to be able to get us through this project. And even when we start, we thought, oh, this is very robust, and we're glad to have this engine. It's grown tenfold since then. Engine does consolidate all the feeds from 33 facilities into respective feeds. Going into it, Philips VisiQ was going to say, okay, for every site that you have, I wanted an ADT feed. So if you think about that, there would have been 33 ADT feeds, there would have been 33 lab feeds, 33 meds feeds. We decided and talked with VisiQ and thought, well, wouldn't it be easier if we could take all 33 of those, merge them into one feed, and only send to you once? Well, you can think about that, the number of, and of course they were going to charge for every feed going in there, as they should, but you can imagine the amount of money saved just by merging these together. So here we're showing, we'll take each one of those facilities, and we're taking ADT, lab, pharmacy, and meds, and merging them all together right into our Express Connect and sending them on to VisiQ. And here's a good chance right here in the bottom right-hand corner. That's actually a picture from Avera's core. So you'll see the 5 monitors on every table. Here, it's probably really hard to see coming across the screen, but it's a little look of the messages that we're getting and sending back and forth through our Summit engine. So here's a little bit about our interface engine. We have 33 facilities on our Summit engine, using one centralized interface engine to connect to not just Meditech, but other HCISs also. We have a centralized data center off campus that has 175 servers in it. That, of course, doesn't necessarily pertain to anything to do with our engine. Right now, and there again, our numbers are growing all the time. At the time I made this slide, we had 230 interfaces running through our engine. I'm pretty positive we're pushing closer to 250 now, and we're processing over 2.25 million messages a day. Now, back when we first started doing this, we were pretty excited that we were pushing about 1 million a week. It's grown a lot since then. So 2.25 million per day. We have a foundation in place to handle meaningful use data exchange and health information exchange integration also. So the benefits of having this interface engine for us have been that it eliminates the point-to-point interface management nightmares, which, yeah, we had tons of those nightmares. We'd be getting those calls in the middle of the night all the time. Right now, it's much easier. We can monitor all that from one place. We can avoid unnecessary costs for an add-on interface, and we'll see that in the next slide. I'll show you just one simple little piece that has saved us tenfold. And just this alone, if we look at the Meditech one over on the left-hand side, that'll represent just for one region, which is McKinnon only, and the ADT that we've got coming out of Meditech. Right now, we're currently splitting that 30 different ways. So we're just making a copy of it, splitting it that 30 ways. And if we all know Meditech, well enough, you can about imagine what it would cost to keep adding on point-to-point interfaces for all those. So I personally think that just for ADT alone, we've paid for this software over and over again. And another one that's probably really hard to read, but it gives you an idea of how much stuff we've got going through the engine right now. You know, everywhere from meds to labs to transcription reports, ADTs, vitals from all of our 7 or 8 different types of vendors. So for us, it's obviously not just eICU. We are using this everywhere. So our advantages of enterprise integration is it's improved our patient care. We have real-time interfacing of critical data. You know, when we first went live with our engine, we of course just had our ADT going to eICU. But then as we started looking at all of our third-party vendors, we realized that we could also be using these feeds for that. So even though it's not 100% necessary to have the feed going to these third-party vendors, we found out that it's such a huge advantage to be sending it there real time, and the end users, just love it. And we're also able to monitor our interfaces from one central location, and that's been that really improves our patient care. Also, we know right away if something's down, and we're able to fix the problem. The faster deployment of integration solutions to departments. There again, if one of those if we were getting another third-party vendor and they said we need an ADT, to go through Meditech and order another instance of that ADT and get it implemented, we could easily be out in 3 months. And literally, I've told plenty of vendors that come on with us since then that they say they need an ADT. They want to know the timeline when they could have one. My standard answer is usually about 10 minutes. And that's just because it takes me a little time to get logged into the server and get it done. We could definitely have an ADT interface up for another vendor in 10 minutes or less. And the improved integration turnaround, there again, much quicker to get it done because we've already got copies of all of those messages sitting there in our engine. So with that, I'll probably turn it back over to Tara and let Matt show you a little bit about the software that we're using here, and then I'll hang around and answer any questions you might have.
Okay, great. Thanks, Josh. Appreciate it. And it looks like, yep, Matt is on as well. Matt, I'm going to go ahead and make you presenter. Again, as mentioned, we are going to do a quick demonstration of the technology that Ross just described. Just so you guys can kind of take a look at how the engine works and get a feel for it. And then certainly if you can hang on, I want to open it up for a few questions. As mentioned earlier, I am taping the presentation here, so we all have a copy of that. Matt, I can see your screen, so it looks good. And I'll turn it over to you so you can show everyone the technology. Thanks so much.
Okay, thanks, Tara. So this is Matt Johnson. I'm product manager for our Express Connect interface engine and Provider Exchange, which is our physician office integration tool. So just a quick review of a little look and feel of Express Connect. We have our ribbon